Good afternoon. Good afternoon, everyone. Medical College Hospital, Kolkata welcomes all the participants for today's RDLS session. Today's topic is determinants of first-line ART regimen in children living with HIV. We'll be discussing case scenarios today. We have with us Dr. Dibyendu Raychaudhuri sir from MCH Kolkata. Dr. Dibyendu Raychaudhuri sir is an associate professor of pediatrics at Medical College Hospital, Kolkata, and in charge of the pediatric dialysis unit. He has undergone short-term training in pediatric nephrology at AIIMS, New Delhi, and has, to his credit, 20 publications in reputed national and international journals. In recognition of his contributions to healthcare, he has been honored with the Purbanchal Pioneer Award and the University of Engineering and Management Excellence Award for his dedicated service to mankind. We welcome you, sir, for today's session and request you to start the session.
Thank you for the nice introduction. Good afternoon, everybody, and welcome to this session. Today, our topic is determinants of first-line ART regimen in children living with HIV, the case scenarios. Objective of these sessions are to discuss and understand the national guidelines on ART initiation in children living with HIV, the goals of ART in children living with HIV, evaluation of a children living with HIV before ART initiation, first-line ART regimens in children living with HIV, and ART in TB HIV co-infected children. So our flow of discussion will be in this manner. Now, what are the goals of antiretroviral therapy in children living with HIV? First, to prolong the survival, then promote optimal growth and development, to suppress HIV replication, and to preserve, enhance, or reconstitute the immune system, and therefore reduce the opportunistic infections, and most importantly, reduce the morbidity and improve the quality of life. In case of children, the age is for growth and development. So promote optimal growth and development is a very important concern in case of management of children living with HIV. Now, steps in preparing a child for ART. First, to identify a caregiver. Caregiver are usually parents, it may be other family members also. There may be need to identify a backup caregiver if primary caregiver is a patient living with HIV. Initial assessment of the child. First, to baseline clinical and laboratory assessment to assess for signs of seriously ill child, to screen for advanced HIV disease. There should be evaluation, diagnosis and management of opportunistic infections including tuberculosis, and baseline psychosocial and assessment of caregiver and the child. Initiation of co-trimoxazole preventive therapy whenever it is needed. Preparing the child and the caregiver for lifelong ART, which is very important before starting the therapy, to prepare the family and the members of the family for adherence to the lifelong ART therapy. Treatment of children living with HIV by ART is not an emergency. So before starting of the therapy, it is important to prevent immune reconstitution inflammatory syndrome. Now coming to the case scenario, this is the case scenario 1. Miss A newly diagnosed HIV infected child whose age is 2 years. She has persistent oral thrush. She has achieved normal developmental milestones but has failed to gain weight and height as expected. His weight is 6 kilograms, which is less than -3 z-scores. Height is 72 centimeter, which is less than -3 z-scores. And CD4 count is 18%, which is 500 per millimeter cube. and his hemoglobin, her hemoglobin is 7 gram per deciliter, so she is anemic. Now these are the questions to manage this child. Number one, what needs to be done before ART initiation? Number two is what is the clinical stage of the child, and number three is CPT indicated in this child? So what needs to be done before ART initiation? First, there should be head-to-toe physical examination. Growth should be assessed. Weight and length or height should be measured. Developmental assessment should be done. Screen for signs of serious illnesses and advanced HIV diseases should be done. Baseline investigations including CD4 count and percentage is required. Screening and management of opportunistic infections including 4A screening for tuberculosis is required. Preparedness counseling after identification of the caregiver should be done. CPT initiated and checked for its adherence in initial visits should be done. Management of severe malnutrition is essential, which may need hospitalization. So before starting of therapy, these points should be considered. Now coming to the clinical assessment, head-to-toe physical examination should be done. Growth assessment, weight and length, height has to be taken. Developmental assessment properly recorded. Now, what are the signs of poor nutritional status? There may be lethargy, oral thrush or sores, difficulty in swallowing, fever, anemia, edema, signs of vitamin deficiencies like glossitis, bitter spots, corneal haziness, muscle wasting, and features of opportunistic infections. Now, how to define advanced HIV disease? For adults and adolescents and children older than 5 years, advanced HIV disease is defined as CD4 cell count less than 200 cells per millimeter cube or WHO stage 3 or 4 event. It includes both ART naive individuals and those who interrupt treatment and return to care. All children younger than 5 years of age who are not already received ART and clinically stable with HIV are considered as having advanced HIV disease. Now, what are the concerns about advanced disease in HIV? There is increased morbidity and mortality rates that is highest, especially during the first 4 weeks on ART therapy. Increased mortality risk persists even after ART initiation and increased risk of HIV transmission. So intensified adherence support at time of diagnosis, ART initiation and during episodes of acute illness benefits people with advanced HIV. Now screening of children living with HIV less than 5 years for advanced HIV disease. What are the role of medical officer for children living with HIV less than 5 years with advanced HIV disease? First, to assess for presence of danger signs and serious illness, screen for presence of severe acute malnutrition, screening and treatment of opportunistic infections like tuberculosis and meningitis, rapid CPT initiation in new cases, and TPT in the absence of active tuberculosis, rapid ART initiation in new cases, and intensive counseling in follow-up. So, what to be done if when there is children living with HIV less than 5 years of age with newly diagnosed HIV infection or those re-entering care after treatment interruption? First, force age tuberculosis screening, any of current cough or fever or poor weight gain, reported weight loss, history of contact with the tuberculosis cases. Then if it is present, then investigation for tuberculosis by medical officer, that is by X-ray chest, sputum, induced sputum or gastric lavage, and medical officer should done check for danger signs like not able to drink, breastfeed, vomiting, everything, convulsions, lethargic or unconscious, stridor in a calm child. Then look for fast breathing, chest indrawing, sunken eyes, skin pinch retract slowly, that is signs of dehydration, fever more than 37.5 degrees centigrade, and stiff neck or bulging anterior fontanelle, which is due to meningitis. In that case, refer the patient for further management of acute conditions, including hospitalization and referral to the higher centers. If that those are absent, then check for severe acute malnutrition and any one of the following, like presence of medical complications, any danger sign, severe dehydration, pneumonia with chest introing, not able to finish ready to use therapeutic food, or breastfeeding problem. Yes, if those are present, then refer the patient for further management of acute conditions, including hospitalization and referral to higher center. If those are not present, then child less than 5 years with any danger signs and or severe illnesses like pneumonia, active tuberculosis, diarrhea, dehydration, or severe acute malnutrition, who clinical stage 3 or 4 conditions, CD4 less than 200 cells, less than 200 cells per millimeter cube, or low CD4%, unsuppressed viral load or of more than 1000 copies per ml. If it is present, then advanced disease management package like initiation of co-trimoxazole prophylaxis, treatment for opportunistic infections, preparedness counseling for child and caregivers on ART and nutrition, rapid ART initiation at the earliest, TPT for children above 1 year of age as per national guideline, immunization as per national immunization schedule, and intense follow-up. If those are not present, then standard package of care that includes treat and stabilize active opportunistic infections and severe acute malnutrition, initiation of co-trimoxazole prophylaxis, preparedness counseling for child and caregiver on ART and nutrition, ART initiation before discharge, TPT and IPT for children above 1 year of age as per national guidelines, immunization as per national immunization schedule, and intense follow-up. Now, evaluation for tuberculosis in children living with HIV. There should be intensified case finding. If there is presumptive TB, that may be presumptive pulmonary tuberculosis or presumptive extrapulmonary tuberculosis. If presumptive pulmonary tuberculosis, then to be done NAT, 2 smears microscopy plus X-ray test. If smear or expert are positive, then it is bacteriologically positive tuberculosis. If smears and NAT are negative but X-ray suggestive of tuberculosis, then it is clinically diagnosed tuberculosis. If smear and CB-NAT negative and along with that X-ray negative for tuberculosis, then it is not a case of tuberculosis. In case of presumptive extrapulmonary tuberculosis, NAT or culture or smear positive specimen for extrapulmonary site, that is extrapulmonary tuberculosis. If there is cytology or histopathology examination, any one or more suggestive of tuberculosis, then it is extrapulmonary tuberculosis. X-ray test and other relevant imaging, any one or more suggestive of tuberculosis, then it is extrapulmonary tuberculosis. So we can go through this. Now, which children living with HIV need evaluation by a pediatrician? It is desirable that all newly diagnosed children living with HIV be comprehensively assessed by a pediatrician conversant with HIV care, and a children living with HIV will specially need a pediatric referral if there is malnutrition, poor weight gain or growth failure, developmental delay, loss of previously attained milestones, associated systemic diseases, seriously ill child, and presence of a systemic opportunistic infections. What is the clinical stage of the child? In this case, clinical stage 4, because there is severe malnutrition and child should be evaluated by a pediatrician. Is CPT indicated in this child? Yes, CPT is indicated in this child as he is less than 5 years of age, irrespective of her clinical stage and CD4 count. So, CPT is given co-trimoxazole 5 ml once a day. What is rapid initiation of ART? Rapid initiation is advised in children living with HIV after appropriate preparedness counseling, and it to be initiated regardless of age, CD4 count, and WHO clinical staging. However, ART is a non-emergency intervention, and treatment, preparedness, and management of opportunistic infection is given priority over antiretroviral therapy, and seriously ill and hospitalized children should be stabilized before antiretroviral therapy initiation. Now, coming to the pediatric ART regimen, following are the key considerations in pediatric ART regimens. Number 1 is abacavir is the preferred first NRTI for ART initiation for CLHIV. Lamivudine is the second NRTI component for all patients. CLHIV less than 20 kilograms will be initiated on dolutegravir 10 milligram based regimen. For children with weight more than or equal to 20 kilograms, dolutegravir 50 milligram film coated tablet is recommended as the preferred third drug. For all children aged 10 years or more and weight 30 kilograms or more, tenofovir is the preferred first NRTI drug for ART initiation in children. ART regimen in children living with HIV are dolutegravir 10 milligram dispersible tablets advised in CLHIV less than 20 kilograms. Dolutegravir 50 milligram, those have said earlier. Dolutegravir 50 milligram film coated tablets can be used in CLHIV with weight more than equal to 20 kilograms. Tenofovir 300 milligram is advised in children living with HIV with age 10 years or more and weight 30 kilograms or more. Now, according to the weight and age of the CLHIV, recommended first-line regimens are following. If weight is less than 20 kilograms, ALD-TG 10 milligram, that is fixed dose combination of abacavir plus lamivudine as per weight band twice daily plus pediatric DTG 10 milligram tablet as per weight band once a day. If weight is between 20 to 30 kilograms, then fixed dose combination of abacavir plus lamivudine twice daily as per weight band plus dolutegravir 50 milligram once a day. If weight is above 30 kilograms and age is above 10 years, then fixed dose combination of tenofovir. So it is tenofovir is replacing abacavir, that is and lamivudine plus dolutegravir once a day 50 milligram. These are the pediatric dosage chart which is followed in giving medicines to the children living with HIV. Now, what are the advantages of DTG 10 milligram DT use in children? It is simplified dosing schedule. It is easier to administer. Taste is better. There is better tolerance and lesser side effects. Faster viral load suppression by this medicine. High genetic barrier for resistance. So, development of resistance is late. Evidence of superiority of DTG compared with ritonavir boosted lopinavir and harmonized with adult regimen. Counseling messages for caregiver and children living with HIV are first explain need for lifelong ART and importance of adherence and viral suppression. This is very important. Explain the benefits of DTG 10 milligram. This is effective, safe and easy to administer. Explain the rate of rare side effects like insomnia, fatigue, headache, rash, which should be reported immediately, and explain about weight gain due to DTG, which may occur. And for that is an exercise and nutritional counseling is required. Explain how to give the drugs. 10 steps to be followed. Specify dosing in weight based, that is dose will be changed as child gains weight. Fixed timing of giving the drugs, and DTG should be taken 2 hours before or 6 hours after taking cation containing antacids or laxatives, sucralfate, oral iron supplements, oral calcium supplements or buffered medications. Now, preparedness counseling for DTG 10 milligram based ART. First, to explain what, that is DTG is 10 milligram is a dispersible score tablets, and explain that a dose must be repeated if the child vomits within 30 minutes of taking the medicine. Specify when. DTG 10 milligram can be taken with or without food. Dose is once a day at a fixed time. Ensure the timing is linked with the routine of the child. And identify who. Primary, it should be given by primary caregiver, usually the mother or father or grandparents or guardian. It is essential to identify a backup secondary caregiver. And what should be the pre-ART activities? Pill swallowing, giving first doses in the clinic or hospital is necessary. Now, important drug-drug interactions with DTG. Here important is polyvinyl cations products containing aluminum, calcium, iron, magnesium and zinc, that is antacids, multivitamins and supplements. So use DTG 2 hours before or 6 hours after polyvalent cations containing product. And in case of rifampicin, if there is co-administration of rifampicin with DTG, then use DTG twice daily. This is very important. Now to summarize the ART initiation in ART CLHIV, first confirm HIV infection through virological or serological testing, then treat and stabilize acute conditions and opportunistic infections. Baseline CD4 testing should be done and other lab investigation should be completed. According to weight and age of the child, the ART should be initiated. If weight is less than 20 kilograms, then abacavir plus lamivudine plus DTG 10 milligram. And weight between 20 to 30 kilograms, then abacavir plus lamivudine plus dolutegravir. If more than 10 years and body weight is less than 30 kg, then as 20 to 30 kg regimen. If more than 30 kg, if there is known renal disease, then as 20 to 30 kg regimen. And if there is no renal disease, then abacavir will be replaced by tenofovir, then tenofovir plus lamivudine plus dolutegravir. Pediatric dosage chart can be referred. This is some prescription. Now case scenario 2, Master B is a 3 years old CLHIV who presented with the altered sensorium for last 2 days and cough with fever for last 1 month. His father was recently detected to have pulmonary tuberculosis, and Master B was admitted and diagnosed to have tuberculosis meningitis. He was started on anti-tuberculosis treatment 14 days ago. His body weight was 9 kilograms, CD4 count is 14%, and hemoglobin is 9.8 gram per deciliter. Is CPT indicated in this CLHIV? CPT is indicated as child is less than 5 years and in clinical stage 4. Syrup co-trimoxazole 5 ml once a day is given as CPT. When should the ART be started in this child with a TB-HIV co-infection? ART to be started after completing 4 weeks of anti-tuberculosis treatment, and corticosteroids should be added adjuvant treatment for tuberculosis meningitis. As this child having meningitis, so for that reason ART to be started after completing 4 weeks of anti-TB treatment. Now coming CLHIV co-infected with tuberculosis. What should be the timing of ART in relation to the initiation of anti-tuberculosis treatment? First, to initiate anti-tuberculosis treatment, then ART should be started as soon as possible within 2 weeks of initiating tuberculosis treatment, regardless CD4 cell count among people living with HIV, except when signs and symptoms of meningitis are present. When signs and symptoms of meningitis present, it will be like this. Among children living with HIV with TB meningitis, ART should be delayed at least 4 weeks and initiated within 8 weeks after treatment for TB meningitis is initiated. And corticosteroids should be considered adjuvant treatment for tuberculosis meningitis. Now, what should be the ART regimen with dose prescribed for him? This is abacavir, lamivudine plus DTG. Abacavir 60 milligram plus lamivudine 30 milligram, that is 1.5 tablet twice a day, with DTG 10 milligram DT tablet 1.5 tab twice a day. So first line ART regimen in ART CLHIV co-infected with tuberculosis will be like this. Weight less than 20 kilograms, all are same except DTG twice daily as per weight band. In case of 20 to 30 kilograms, ALD all are the same except DTG 50 milligram twice daily. and weight above 30 kilograms and age above 10 years, there should be an additional dose of dolutegravir 50 milligram after 12 hours. So here we are seeing that the DTG made twice daily if there is co-infection of tuberculosis. This is DTG dosing for CLHIV with dispersible tablet, 3 kilograms to 5.9 kilograms, half tablet twice a day, 6 to 9.9 kilograms, 1.5 tablets twice a day, 10 to 14.9 kilograms, 2 tablets twice a day, and 15 to 19.9 kilograms, 2.5 tablets twice a day. If it is more than 20 kilograms, more than equal to, then 1 tablet of DTG 50 milligram field-coated tablet twice a day. DTG dose will need to remain twice daily for 2 weeks after the last dose of rifampicin. No need to change dosage of DTG in drug-resistant tuberculosis cases. Now, this is the case scenario 3. Master C is a CLHIV aged 8 years, presently asymptomatic. Clinically stable, there is no opportunistic infections. His weight is 24 kilograms. CD4 count is 386 cells per millimeter cube. Hemoglobin is 12.6 gram per deciliter. All other investigations are within normal limits. Now, if CPT is indicated in Master C, the age is 8 years and CD4 count is 386 cells per millimeter cube. CPT is not indicated in child as clinical stage 1. CD4 count is more than 350 cells per millimeter cube and he is more than 5 years. Now prescribe the ART regimen with its dose. ART regimen will be ALD and the dose is abacavir 60 milligram, lamivudine 30 milligram, fixed dose combination, 3 tablets in morning and 3 tablets in evening with tablet dolutegravir 50 milligram once a day. Is CPT now case scenario 4? Miss D is a 14-year-old CLHIV. She is asymptomatic, clinical stage 1. Her weight is 38 kilograms. Hemoglobin is 10 milligram per deciliter and CD4 count is 458 per millimeter cube. In her renal function tests, it is seen that it is within normal limits. Other investigations all are within normal limits. If CPT is indicated in this case, no indication of CPT as it is a clinical stage 1 and CD4 count is 458. Prescribe ART regimen with its dose. Answer is TLD as tenofovir can be used in CLHIV aged above 10 years and body weight beyond 30 kilograms. Dosage is 1 tablet of TLD once daily at any time fixed as per patient's convenience. So can we give DTG 10 milligram 3 tablets for CLHIV weighing 20 kilograms to 29 kilograms? Dispersible pediatric DTG is not bioequivalent with the film-coated DTG 50 milligram. Very important. In fact, 30 milligram of dispersible DTG is equivalent to 1 film-coated of 50 milligram DTG. So 1 film-coated DTG is 3 tablets of dispersible DTG 10 milligram. So use DTG 10 milligram dispersible tablet for children up to 19.9 kilograms. DTG 50 milligram film coated tablets for children more than equal to 20 kilograms. So options for children 20 kilograms or more not able to swallow film coated tablet. In that case, DTG 50 milligram tablets either may be split into halves followed by immediate ingestion of both halves of the tablets or crushed and added to a small amount of semi-solid food or liquid, all of which should be consumed immediately, or DTG 10 milligram DT tablets given a dose of 30 milligrams, that is 3 tablets. So in place of 50 milligram of DTG, we can give 3 tablets of dolutegravir dispersible tablet. So can DTG 10 milligram be taken with food or milk? DTG 10 milligram may be taken without meals. DTG 10 milligram dispersible tablet should be ideally dispersed in water. It can be taken with milk or food. it is a dispersible tablet and should be dispersed into a solution and then given. So these are the important websites, and if your child does not like the taste of pill in water, the medicine can be given with juice, curd or milk, etc. These are the important links and important handout to uh, swallow to feed the medicines, like dose determination, prepare DTG 10 milligram mixture, give mixtures to the child. So these are the steps, and these are the apps for treatment guidelines for HIV, which can be downloaded through the Android phones. So this is our dream and HIV free generation. Thank you all.
Sir, for facilitating this session. Any questions from the participants? Please feel free to unmute your mic and ask questions, or you can also put your questions in the chat box. Any questions? So I don't think there are any questions. We'll quickly run the feedback form, sir.
Okay.
Sir, one question is there. Sir, I am Senior Medical Officer Dr. B.N. Tripathi from Bhubaneswar ART Center, sir.
Yeah.
A nice presentation. My question is, sir, at what stage, because we usually prefer AL with dolutegravir in case of children. So at what stage we can give adult dose of AL tablet? At what weight band of the child we can give adult dose AL?
At what weight of the children you can give the adult dose?
Right. My
This
question.
is your question, I think. No.
Yes, sir.
Okay. So you can go through the chart table. Okay, you have with it. From there, you can find your question, answer to your question. So I'm searching for it. Just wait a minute. So you go through the weight band chart, which is with you, and there you'll find the answer.
Okay, okay, sir.
Anything else?
Any more questions? So I don't think there are any questions. Thank you so much for facilitating this session. The
Okay.
feedback poll is now visible on your screen. Participants are requested to please attempt the feedback poll. Do not close this window. First, attempt the feedback poll and only then you can leave the meeting or the session. There are 5 questions in all. Please scroll through the questions and click on the answer of your choice. Requesting everyone to please attempt the feedback poll. You just need to click on the answer of your choice.
फिल कर दिया मैम.
Thank you, sir. Kiran sir, we can end the e-poll now. Thank you, sir. Thank you to all the participants for patient listening. We'll conclude the session now.